Yeah.
Perfect. Thank you very much. And I'm going to be very brief with my presentation. I do not have any financial disclosure, but at the upfront, I have to tell that my experiences with ICL and IPCL, so I'll stick to that. However, the principle still remains same for all these lenses. These are ciliary sulcus fitted lenses. Why we talk about sizing? Well, because we know that irrespective of whatever best hands, whatever we have, we still have cases where we have to explant ICL, IPCL. And in these cases, there is something which is related to the vault or the sizing of the ICL. When we talk about phakic oil sizing, most important parameter for the sizing is vault. Now, vault is nothing but we know that it's nothing but the back surface distance between back surface of the phakic IOL and front surface of crystalline lens. And the ideal vault is somewhere between 250 micron to 750 micron, depending upon the individual cases. But what happens if the vault is not accurate? What if the vault is very high? Well, in that case, there can be angle closure, there can be pigment dispersion, and there can be sometimes rare endothelial damage also if periphery is touching the peripheral endothelium. Low vault can lead to cataractogenesis, and there can be rotational instability of phakic oil. These vaults can be reliable based on what technique we use. Now, I use hydroinsertion. So there is no viscoelastic used during the procedure, whether loading or implanting the lens. Hence, the vault can be reliable a little earlier. But if you use viscoelastic, which is absolutely fine, then you have to wait till the viscoelastic absorbs. So if visco is in front of the lens, there can be falsely low vault. If it is behind, then it can be falsely high vault. The parameters which are very important, as Kamal was describing, which is one is AC depth, horizontal white to white, and power, of course. The interior chamber depth usually is analyzed using contact techniques like ultrasound A scan. In that, we have to detect the pachymetry, or UBM, or optical devices like IOL Master, Pentacam, OpScan, ASOCT, and those things. By default, cutoff limit for both the lenses is 3 millimeter, but sometime you can go lower also. We'll come to that later on. But beyond AC depth, you also should be looking at possibility of any angle anomalies and all those things. So get a good gonioscopy done, look for any peripheral cyst in the iris, and also look at the configuration of iris. As you can see from here on the right side, that iris can be flat configured, it can be convex, or it can be concave. And along with this thing, as previous speakers spoke about crystalline lens rise, which is very important. When you join these two lines between the edge of the iris, part of the lens which is in front it's called crystalline lens rise. Higher the rise, there are chances that you can end up with a low vault. Now, horizontal white to white by default is measured using digital caliper. Patient in supine position, and you go in the middle of the limbus. Again, there are a lot of debate which can be middle of the limbus, clear cornea to clear cornea. There's no clear answer to that because we are still going to put the same size lens there. I will come to that later on. However, please remember, different instrument can have significant variability in individual. Now, this is my own right eye, and you can see Pentacam, IOL Master, keratograph, eye design, everything has different white to white measurement. So which one is right? Well, the ideal thing is you should go with two methods. One method, whichever suits you, be consistently with that. And the second method has to be your digital caliper. Please remember cases like VKC where they have pigmentation, your optical methods can be sometimes faulty. So what I prefer to do is I prefer my Pentacam where I do image inversion. And then what I do here, as you can see here, horizontal slit, and I do image inversion. And with the caliper, I measure myself the white to white. The same thing I feed in my digital caliper, and then I confirm on the patient. The advantage there is the digital caliper can have its variability, and to avoid that, you can possibly know exactly what white to white is. Now, but whatever we do, please remember, the lens we are putting in sulcus, but we are measuring white to white. Now, how does that help? Well, by default, we feel that horizontal white to white is 0.4 millimeter to 0.5 millimeters smaller than sulcus to sulcus. But that's not always true, because there are enough studies which show very poor correlation between sulcus to sulcus and white to white. So you cannot always trust on that, but irrespective, we still have to believe one thing. Now, if you have certain UBM like Quantil here, you can actually measure sulcus to sulcus also, and you can actually see the vault on ICL, there are simulated vault, and which can work very well. But does it mean sulcus to sulcus is best? Well, interestingly, that itself has its repeatability. Just last week, I had one patient. I did sulcus to sulcus measurement and white to white, which was different. I went by sulcus to sulcus, and I had to explant the lens and put the lens which was sizing absolutely proper according to white. So not always sulcus to sulcus also works. Coming to the trick of sizing, I'll give you the small concept here that a same size lens, if you put in a larger eye, you will have low vault, and the eye size which is smaller, you will have high vault. Now, based on this thing, if you go by this, that this is with the 3 millimeter AC depth, I've calculated the lens suggested through the calculator. And if somebody's white to white is 11.7, well, the lens would be 13.2, which is 1.5 millimeter larger than the white to white. And even if it's 12.3, the calculator will still tell you 13.2, which is 0.9 millimeter larger only. So where do you think vault will be high? Well, of course, where the difference between the lens and the size is more, where vault is going to be high. Now, the problem is when you have low AC depth and your range is coming in the first part, that's where you can have higher issue of the post-op outcome. So please be aware that when such kind of cases you're dealing with, you may want to have decent AC depth. Coming to the calculation about the toric, here I'm taking the example of IPCL. Now, what if we have 11.65? The calculator will tell you 13 millimeter and 11.
Dr. Himanshu, I'm so sorry, just a gentle reminder, you have only a minute to go. Thank you.
So if where would you have low vault? Well, we know that where the difference is less, the vault will be low. So in such kind of case, instead of going by what calculator tells me, I go one size higher. And what it does, it gives me rotational stability, and the vault will increase by 60%, which is like 150 micron. So with this thing, I end my talk, and thank you very much for your patient listening. Thank you.